So this was a case of Staar ICL. How did we come to the conclusion? It was a very regular case, 5 with 2 cylinder, 2.25 cylinder. However, grandfather had history of glaucoma, so we just wanted to rule it out. It showed no form thrust keratoconus, so it seemed like a straightforward case. However, if you see here, it is showing that the cornea is a little weak, and in both the cases, the bad index, the red line is going down. We had enough anterior chamber depth, and the white to white came to 11.7, 11.8. We did all the other measurements required for good AC depth and open angles. On the corvis, we found that it was in the red zone, and that means the cornea in both the eyes was not mechanically that strong. So decided to go ahead with an ICL, and if you see here, you have to go with a vernier caliper, put paracaine, and then make the caliper larger than what it is, and then with slight pressure, you see, you just bring it in a little such that the white to white is measured. And generally there is a slight difference between the caliper white to white and your optical biometry white to white. The biometry white to white is a little more. The exact biometry and vernier caliper difference is told to you by the company because it's different for different biometers. This was one eye and this is the other eye. Done the same thing. I also measure it with calipers which are used for our squint cases, and then put it head to head with the actual vernier caliper, and this gives a very consistent reading of a difference of 0.3 or 0.4 between the optical biometer and the actual vernier caliper. Now you first take the cartridge and just fill it with BSS. That's all. And you have to be very careful of how you place your fingers to position the cartridge. So with the left hand index and thumb finger, I am holding the tip, and I have now filled, after with BSS, I have filled it with viscoelastic. Now you pull out the ICL from the bottle with the sponge tip given to you, and you place it with the convexity superiorly into the cartridge. This loading is extremely important. It's a very sticky tip. So now see, I go with the flat surface towards it, push it towards the opposite side, and now twist my wrist or twist the fingers such that it rolls in, like it rolls in to the cartridge. If you just push it and come back, it will come out again. You have to push it towards the left and then turn your hand anti-clockwise at the wrist or at your fingers, and now you have loaded it such that all 4 haptics are within. And if you see, the trailing 2 haptics should be at an equal distance away from the edge of the cartridge. It shouldn't be that one is 2 out and one is 2 in. If that is so, just push it accordingly. The one which is out, you have to push it in. Now with the right hand, just see how I have held it. With the index finger and the thumb, I have held the cartridge. With the ring finger, I can give a little support. On the middle finger and the thumb, I have held the cartridge. With the index finger, I am pushing the lens, as you could see. We need to support the lens to give counter pressure. With the left hand, we come in with the special forceps. You can see the edge. Now I opened the jaws. I am giving good counter pressure with my right hand. And now take a good bite and a good grasp, almost up to that first dialing hole, and hold it tight. Don't be afraid to tear the lens. Grasp it well. And now the key trick here, if you see, is you do not move your left hand backwards. The right hand with the cartridge has to go backwards. So this is more like when you're sitting in a train and looking outside, you feel the trees or the other train is moving in the other direction, or the trees are moving the other direction, or if you're sitting in a stationary train and you see a running train pass by, you feel that you are the one that's moving. So here it's exactly like that. The right hand is moving backward, the left hand is staying stable as it is. And this is the trick, because here is the most important part, or here is where you will tear the lens. So if you pull the lens with your left hand, it will tear. If you hold the lens with your left hand and just pull the cartridge backwards, it will not tear. Now you refill the cartridge with a little viscoelastic, and now you need to place this on the side in that trench so that it is not tilted. Now we have to load the injector. So there is this sort of case given, and you push the soft tip sponge in it, and now you put the case with the sponge tip, and you have to click it. You can hear a click, and once you click it in, the stick, which is like an earbud, the end which doesn't have the bud gets clicked in, and this movement of moving it up and down shows that it has clicked in well and it is engaged properly. Now you squeeze the base as you saw to put it in, and then turn it and click it. Now I can see the marking on my digital marker, which is not seen here, and I do the correct marking. But if you don't have that also, you've done a certain marking, you know where it is, and just like a toric IOL, you do your marking and you decide the axis you want to place it. I've seen if the cornea is really dry when you're doing the marking, you get very sharp, clean marks. Now compared to a cataract surgery, what are the differences when you make the side port main incision? In a cataract surgery, we are going to create a capsulorhexis and remove the anterior capsule anyway. Here we have to preserve the anterior capsule, so don't go at an angle where it can touch the anterior capsule. You can be a little superior angle, I would say, rather than going parallel, and just fill the chamber, not too much, but once these lines of the viscoelastic merge and become even, that is correct. Don't overfill the chamber. Once again, I make the second side port after I have put the viscoelastic, because that gives me more depth. We do not want your MVR blade to touch the anterior capsule. The same holds true when we are making the main incision. We go a little upward and then in, and especially when you are entering, we do not have the luxury of touching the anterior capsule. So after you go in also, I am going a little more upward rather than downward. And always in these cases, you need to extend the wound a little bit by 0.2 millimeters or so, just enough to allow the cartridge to go in. So if it's a 2.8, I make it around 3.2. Now we enter the anterior chamber, and you see how this lens has to be injected quite slowly, and it unfolds itself. Sometimes you find it difficult for both sides to open equally. If, let's say, the right side is opening more slowly, you need to turn your wrist towards that side such that that area goes a little downwards and the other area goes upwards. So here it is like a laughing Buddha, I can say, with the arms on top, and then the arms are unfolding and opening. Now we inject a little viscoelastic on top so that the lens settles in. Such a dilated pupil makes it difficult for the surgeon to go below the iris. So it may be a good idea pre-operatively to just put one drop of dilating drop before the surgery rather than dilating it like a cataract case. So now this spatula is given to you, and you have to just go below, pull the haptic or the plates or the bunny ears towards the center, and then nudge them under the iris. This is not very difficult. Just be very gentle. We don't want any lens touch. So we got the two haptics in, and you get the other two haptics in the same way. And now if you see the center hole in the ICL, it allows the egress of the viscoelastic. So I like placing my aspiration cannula around it, and you will see that the central hole is never exactly in the center, which is absolutely fine because it will take the position of the center of the cornea, and that may not be the center of the pupil. So do not worry about it. That's exactly how it is supposed to be. And I've put a little pilocup in so you could see the pupil contract over the lens. This stabilizes the lens. You can rotate it clockwise or anti-clockwise so as to align the axis with your markings. So that's the end of the case. Both eyes were done. Patient was extremely happy. What it looks like the next day, dilated and undilated, we will see shortly. This is the dilated look, and this is the undilated look. Patient was 6'6" N6 the next day. Both eyes were done 4 days apart.